a patient's temperature ticks up just a little bit. We're talking 100.4 degrees Fahrenheit or exactly 38 degrees Celsius.
Right. Barely a fever.
Yeah, I mean, if you or I spiked 100.4, we might just grab some Tylenol, maybe pull up a blanket and, just ride it out on the couch.
Totally. But in an oncology patient, that exact same number on the thermometer is a blaring, life-threatening siren.
It's terrifying. You have less than 60 minutes to get blood cultures drawn and hang broad-spectrum IV antibiotics.
Exactly. Because if you brush it off as just a mild fever, that patient could spiral into irreversible septic shock before your shift is even over.
Time is tissue and time is life.
Absolutely. So welcome to an episode of the Super Nurse Podcast. Today, we are immersing ourselves in the curriculum created by Brooke Wallace.
And just to be completely clear right off the bat, we are not Brooke Wallace.
We are not.
Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor, and a published author. We are just your hosts, guiding you through her incredible bedside knowledge, her meticulous notes, and her signature teaching style.
Right. And the mission here is to help you, nursing students and new nurses, actually apply all that school knowledge to real patient care.
Yeah, we want to connect that dense textbook pathophysiology directly to your physical assessments and your clinical judgment.
We're focusing on how to think, not just what to memorize.
Exactly. And before we get into the heavy stuff, a quick reminder, make sure to subscribe and watch the comic book-based video for this material on YouTube.
Oh, yeah, it's so good.
The link is in the description, and the channel is called Super Nurse Comics. It is a fantastic visual tool to pair with all the clinical concepts we're breaking down today.
Highly recommend it. So, to safely manage a high-stakes oncology emergency like that sudden fever we talked about, you really have to start by understanding the specific cancer story of the patient sitting in front of you.
Right, the cancer story.
Yeah. That means knowing the type, the location, whether there are metastases, and crucially, what the goal of treatment is. Is it cure, control, or comfort?
Because that changes everything. And when I try to visualize what cancer is actually doing to the body on a cellular level, I like to strip away the medical jargon.
Same.
A tumor is essentially this rogue, highly metabolic parasite. It's actively building its own custom blood supply.
Angiogenesis.
Yes, angiogenesis. And it does that just to siphon off the body's glucose and nutrients for its own growth. It's so selfish.
It really is. And translating that internal pathophysiology to the external assessment is where your clinical judgment actually begins.
Right.
When a rogue tumor is stealing that many nutrients, the most obvious outward sign is going to be unexplained weight loss.
Huge red flag.
Exactly. The evidence tells us that if a patient drops like 20 pounds rapidly without any new diet or workout routine, the clinical alarm bell should be ringing. The tumor is literally starving the rest of the body.
Leading to that severe muscle and fat wasting, right?
Yeah.
Cachexia.
We've got to Cachexia.
Yes. And when we're taking a patient's history, clinical experience shows there is a specific word that acts as a massive warning sign in oncology.
Oh, I know the word you mean.
Yeah, the word is persistent.
Persistent, yes.
Like a persistent cough, persistent hoarseness, persistent indigestion. It implies that a symptom is just sticking around despite normal everyday measures that should have fixed it.
Because the anatomy is fundamentally altered.
Exactly.
So let's apply that altered anatomy to a real bedside scenario.
Yeah.
Say a new nurse reads a patient's chart and sees a T4 colon cancer based on their T&M staging.
Okay, with T standing for tumor size?
Right. That completely changes your morning assessment.
If I see T4 on a chart, my mind immediately goes to the sheer physical space a tumor that size takes up. I mean, if it's a massive invasive mass in the colon, I'd imagine the plumbing is getting crushed or completely blocked.
You are anticipating a mechanical complication before the patient even complains of the worst pain.
You have to be hypervigilant.
Yes. Your assessment requires listening carefully for absent bowel sounds and actually palpating for a rigid abdomen. You are actively hunting for a bowel obstruction.
Because the physical presence of a tumor causes other oncologic emergencies, too. I mean, if that mass is in the upper chest, it can compress the superior vena cava.
Right, superior vena cava syndrome, or SVCS.
Which is terrifying for the patient.
Extremely. The blood trying to return from the head and neck gets trapped because the vein is literally being pinched shut by the tumor. You'll notice facial swelling, distended neck veins, and just sudden shortness of breath.
Or if the tumor is pressing against the spine, you get spinal cord compression, which presents as severe back pain, maybe new weakness, or sudden loss of bowel and bladder control.
Right. The location of the tumor tells you exactly which emergency to anticipate.
It's all connected. So once you understand the physical impact of the tumor itself, you have to monitor the systemic fallout of the treatment.
Because chemotherapy is systemic, meaning it circulates throughout the entire body.
And it's designed to just carpet bomb rapidly dividing cells, which is highly effective for killing cancer, obviously. But the body relies on its own normal, healthy, fast-dividing cells to survive.
Yeah, it catches friendly fire.
Exactly. And the biggest, busiest cellular factory in the human body is the bone marrow.
The bone marrow is churning out billions of blood cells constantly. So when chemotherapy hits, that factory basically shuts down.
It's brutal.
It leads to bone marrow suppression, specifically a condition called pancytopenia, pan meaning all, cyto meaning cell, and penia meaning deficiency.
Let's break down the bedside logic of that factory shutdown, because this is what you see every shift. Say I'm looking at my morning lab report. First, the red blood cells drop, causing anemia.
Right, so the patient is going to be hypoxic and experiencing extreme bone-deep fatigue.
Because they literally lack the hemoglobin vehicles required to carry oxygen to their tissues.
Makes total sense when you picture it. Then the platelets drop, resulting in thrombocytopenia. Platelets are your clotting factors.
Right, the body's little repair guys.
Exactly. And clinical experience shows that when levels drop under 100,000, the bleeding risk is severe. You must look beyond the lab value to the patient's actual skin.
Checking for oozing at IV sites, or those tiny red dots?
Petechiae?
Yes, petechio. Or larger bruising called ecchymosis.
Spot on. And then the white blood cells drop. Neutropenia. The body's defense grid is just completely offline.
We are specifically looking at the ANC, right? The absolute neutrophil count.
Yes, the ANC. When that drops, the patient has virtually no ability to fight off even the mildest pathogen.
Which brings us directly back to that 100.4-degree fever we discussed at the start, febrile neutropenia.
The ultimate emergency.
So honestly, let's play devil's advocate for a second. If I'm on a busy med-circ unit with 5 other patients, my instinct might be to just give them some Tylenol, document it, and check back in an hour to see if the fever broke. I mean, why can't we do that?
Giving Tylenol in that scenario is like unplugging the fire alarm while the house burns down.
Wow, okay, that paints a picture.
It really is. Fever is an inflammatory response. In a patient with a decimated immune system, that fever is quite literally the only warning sign you will get that a massive infection is taking over. The fever isn't the problem, it's the alarm system.
And unplugging the alarm doesn't put out the fire. The infection is still raging.
Exactly.
Yeah.
You must immediately follow sepsis and neutropenic fever protocols. That means drawing blood cultures first to figure out exactly what pathogen is attacking, and then hanging broad-spectrum IV antibiotics within 1 hour.
A race against time to stop septic shock.
It truly is.
That drastically reframes how I look at a simple thermometer reading. Now, we also need to talk about the organs filtering these toxic drugs, because chemo doesn't just suppress the bone marrow, it can be incredibly harsh on the kidneys and liver.
Oh, absolutely. Take a drug like cisplatin, for example. It is highly nephrotoxic.
I have a great memory trick for that one. Think of cisplatin as pisplatin because it destroys the kidneys.
That is hilarious, but so accurate. You have to monitor their kidney function relentlessly, tracking a creatinine climbing over 1.3 or a BUN over 20.
And monitoring urine output is non-negotiable. If it drops below 30 milliliters an hour, those kidneys are in acute distress.
Yeah. And sometimes the kidneys get overwhelmed not just by the drug, but by the cancer cells dying.
Wait, you mean if the chemo works too well?
Exactly. If a massive amount of cancer cells burst all at once, they dump their internal contents directly into the bloodstream.
Oh, tumor lysis syndrome.
Yes. It is a massive oncologic emergency. The bursting cells dump huge amounts of potassium and uric acid into the blood.
So the uric acid crystallizes in the kidneys, causing acute renal failure.
Right. While the sudden hyperkalemia can trigger lethal cardiac arrhythmias.
It's fascinating in a terrifying way that the treatment successfully killing the cancer can simultaneously cause a lethal emergency.
It's a very fine line we walk in oncology.
So if chemo is ruthlessly targeting the bone marrow because those cells divide rapidly, it makes sense that the epithelial lining of the gastrointestinal tract, which replaces its lining every few days, is catching the exact same crossfire.
The entire GI tract takes a massive hit. And as those fast-growing cells in the gut die and break down, They release massive amounts of serotonin.
Wait, serotonin, I usually think of that as the neurotransmitter for mood regulation,
Yeah.
not, something causing severe nausea and vomiting.
It's wild, but it plays a huge role in chemotherapy-induced nausea. That dump of serotonin from the dying gut cells travels up and directly stimulates the chemoreceptor trigger zone in the brain.
Which totally explains the bedside logic of giving specific medications like Reglan or metoclopramide.
Exactly.
It's not just a generic stomach settler. It is a medication that specifically targets and blocks that antiemetic pathway in the brain.
Understanding the underlying mechanism of the drug makes you far more effective at proactive symptom management.
You're not just passing pills, you know why it works. And those dying epithelial cells also cause stomatitis or mucositis, right? Like painful raw sores covering the inside of the mouth and throat.
Yes, and for bedside interventions, you have to offer viscous lidocaine.
So what does that do exactly?
Well, it's thick and sticky, coating the inside of the mouth to provide a local anesthetic effect. That way, the patient can actually tolerate swallowing water or food.
Makes sense. And I'm guessing you should strictly avoid any alcohol-based mouthwashes like Listerine.
Oh, absolutely. Putting alcohol on raw, open mucosal sores would cause agonizing pain. You want to use gentle saline rinses instead.
Ouch. Yeah, no alcohol. Here's another area where our standard nursing instincts might lead us astray. When a patient is suffering from severe cancer-related fatigue, perhaps combined with chemotherapy-induced peripheral neuropathy, that tingling, burning numbness in the hands and feet, our natural instinct is to tell them to stay in bed and rest.
It feels incredibly counterintuitive,
Wow.
but the evidence tells us that too much bed rest actually worsens cancer-related fatigue.
Really? So rest makes it worse?
Yes. So we encourage energy conservation, but paired with light, consistent exercise.
Getting up and doing light walking combats physical deconditioning.
Exactly. And for the neuropathy, movement stimulates blood flow to the extremities, supporting nerve health and helping manage that tingling pain.
That is so good to know. We also need to differentiate the systemic effects of chemotherapy from the localized effects of external beam radiation.
Right. They're very different.
Radiation acts more like a highly focused, high-energy flashlight aimed directly at the tumor. So the patient doesn't typically experience those systemic GI side effects from it, but the skin, right where that beam enters the body, takes a massive hit.
It reacts very much like a severe localized sunburn.
And protecting that fragile skin requires strict bedside care. You have to avoid anything that causes friction or traps heat.
No tight closing over the irradiated area.
Right. And no scented lotions containing irritating chemicals, and definitely no powders, which dry the skin out further and just increase friction.
Speaking of tissue damage, we have to look closely at how we safely deliver these harsh chemotherapy medications into the body in the first place. We rely heavily on central venous access devices, or CVADs.
Because many of these drugs are vesicants.
Yes, highly toxic to tissue.
If you push a vesicant through a tiny peripheral IV in the hand or arm, and it leaks out of the vein into the surrounding tissue, it will literally cause that tissue to necrose and die.
It's awful.
So we use central lines, like implanted ports, to deposit the drug into a massive vein near the heart where it is instantly diluted by high blood flow.
And accessing an implanted port requires a specific non-coring needle, often called a Huber needle.
Okay, what makes a Huber needle so special? An implanted port has a silicone septum, right? Like a rubbery window under the skin.
Yes. And a standard hollow needle acts like an apple core. Every time you push it in, it carves out a tiny plug of silicone.
So after a few accesses, the port would just permanently leak?
Exactly. A non-coring Huber needle is sliced at an angle so it parts the silicone like a curtain. When you pull it out, the silicone seals right back up, preserving the life of the port.
That's brilliant engineering. And because this line provides direct access to the heart, infection control is an absolute priority.
Preventing a CLAB is I, a central line-associated bloodstream infection, is central to oncologic nursing.
So meticulous sterile technique, specifically aseptic non-touch technique, is required. Both the nurse and the patient must wear masks, right?
Yep. To prevent respiratory droplets from contaminating the sterile field while the dressing is changed or the port is accessed.
And when cleaning the site with chlorhexidine, or CHG, it requires a full 30-second back-and-forth friction scrub.
You are physically digging the bacteria out of the microscopic crevices of the epidermal layer.
And you have to let it air dry completely and naturally. I see people trying to blow on it or fan it with their hand.
Oh, you cannot do that. That just pushes environmental bacteria or bacteria from your own mouth right back onto the sterile site.
Such a common mistake. Let's talk about flushing those central lines. Hospital protocols universally state that you must use a 10 milliliter syringe or larger when flushing a CVA.
Yes, always.
But if I'm just pushing normal saline to clear the line, why does the size of the plastic syringe matter?
It comes down to the physics of pressure, specifically pounds per square inch. A smaller syringe, like a 3 milliliter syringe, concentrates the force of your thumb into a much smaller surface area, generating significantly higher pressure inside the catheter.
Oh, wow. So if there is a tiny clot or a kink inside that central line, the high pressure from a small syringe can literally rupture the internal catheter line inside the patient's chest.
Yes, a 10 milliliter or larger syringe distributes that force, creating lower, safer pressure.
That makes perfect sense.
You also have to remember to discard the first 5 to 10 milliliters of blood if you are drawing a lab sample from that line, ensuring your sample isn't diluted with the saline or heparin sitting in the catheter.
Good tip. Which brings up a jarring contrast in oncology care. We are meticulously accessing these central lines to deliver life-saving treatments, but the drugs themselves are so toxic they turn the patient's immediate environment into a hazardous material zone.
It's true. For roughly 48 hours after administration, the patient is actively excreting the hazardous chemotherapy drugs.
And traces remain in all bodily fluids: urine, stool, vomit, sweat, and semen.
Everything.
It is wild to think about. We are infusing a chemical into a human being to save their life, but if a drop of that same chemical touches the floor, it requires a hazmat response.
That's why we have to provide rigorous home safety education for the patient and their caregivers to navigate this.
So what's the biggest danger zone at home?
Definitely the bathroom. Flushing a toilet creates an invisible plume of aerosolized droplets.
Right.
So patients must be taught to close the toilet lid before flushing, and they need to double flush to ensure the hazardous waste is completely cleared from the bowl.
Okay, double flush, lid down. What about laundry? Like, if a patient wakes up drenched in sweat, that sweat contains chemo traces.
Caregivers handling those linens must wear nitrile gloves. Specifically nitrile, not latex, because chemotherapy can permeate latex.
Important distinction.
Very. And those linens must be washed twice in hot water, completely separate from the rest of the household laundry.
We also have to educate them on the bright yellow home spill kit. Like, what if a patient goes home with a continuous IV chemo pump and the tubing snags on a doorknob and the line disconnects and leaks fluid onto the floor?
It happens. And the family has to deploy that yellow spill kit. They put on double nitrile gloves, use the highly absorbent pads to soak up the fluid, and place every single contaminated item into puncture-proof yellow hazard bags.
And those yellow hazard bags must be returned to the clinic or hospital for specialized incineration, right? They can never be thrown into regular municipal trash.
Never. And if that chemo splashes onto the caregiver's skin when the line breaks, a quick rinse under the sink is completely inadequate.
They need to wash it thoroughly.
They must wash the area continuously with soap and copious amounts of water for a full 5 to 15 minutes.
Wow, up to 15 minutes.
Yes, to manually remove the chemical and prevent it from permeating the epidermal layers and entering their own bloodstream.
Dwelling on that 15-minute wash rule really emphasizes the gravity of the medications we are handling.
It really does.
Our bedside logic has to be incredibly sharp to manage the physical toll of these treatments. But as we wrap up this clinical discussion, there is a profound psychological element to oncology nursing that requires the exact same level of vigilance.
I'm so glad you brought this up. It is remarkably easy to get tunnel vision, focusing solely on the lab values, the IV pumps, and the hazardous precautions, while completely losing sight of the human being enduring them.
Clinical experience tells us that nurses often document something like alopecia hair loss simply as an expected physical side effect. We check a box on the flow sheet, offer a warm blanket, and move on to the next room.
But for the patient, it is a traumatic stripping away of their privacy and identity.
Yeah. Exactly. As long as a patient has their hair, they retain the power to choose who they share their diagnosis with. They can go to the grocery store, pick on their kids, and just blend in.
But once their hair is gone, the cancer becomes public. Everyone knows. They lose control over their own story.
The challenge for every nursing student and new nurse listening is to adjust your perspective. What if you approached your patient's psychological loss of control with the exact same fierce urgency as you do a dropped blood pressure or a neutropenic fever?
I love that. Listening without forcing toxic positivity, communicating with honesty, and just advocating for their dignity fundamentally changes the way you practice nursing.
It bridges the gap between treating a diagnosis and caring for a person. Thank you for joining us for this session of the Super Nurse Podcast. Remember, your critical thinking is your absolute best bedside tool. Keep learning how to think, not just what to memorize.
An X-ray or a lab report might show you the numbers, but in oncology, your comprehensive bedside assessment is what truly brings the patient's picture into focus.
Until next time, stay curious and stay vigilant.